So my topic is on examination of tremor. Tremor is shaking movements in one or more parts of the body, often in the hands. And the typical technological definition is it's oscillation of muscles. It is flexion and extension of the group of muscles, and it is a rhythmic movement. It's more like a medical technical definition, but the simple terminology, it is shaking movements in one or more parts of the body, often in the hands. It can happen in the arms, legs, head, vocal cords of the body. So we have to look for the tremor in the arms, tremor in the legs, tremor in the head, tremor in the vocal cords in the form of voice tremor and body tremor when somebody complains of shaking in the hands. Can be intermittent or constant. So we have to look sometime patiently, observe the patient for at least 1 or 2 minutes to make sure that we are missing some tremor which is coming and going. It can be independent or as a result of another disorder. So it can be just a tremor with no underlying medical disorder, or it can be a manifestation of some other underlying medical disorder. It is not life-threatening. If it is independent tremor, it can be disabling, but there are sometimes underlying medical disorder due to different reasons. They can have prognosis depending upon the underlying medical disorder. It can affect work and day-to-day tasks like bathing, dressing, writing, and eating. So when we see the patient, we have to ask them that in which way the tremor is disturbing. Is a very important question to ask. The tremor may be triggered by stress, physical exhaustion, certain postures, and certain movements. So we have to ask what makes a tremor to come, what makes a tremor to become worse, and what you do to make it better. So all these questions to be asked to the patient. It is common among mid to late age, can occur at any age. Men and women are equally affected. It is caused by problem in the deeper parts of the brain, like subcortical region, the main the basal ganglia, thalamus, and the brainstem, and all these things can involve play a role in the manifestation of the tremor. The physiological the circuits can play a role. So, and sometimes the structural problem affect physiology of the brain that makes the tremor to manifest. Some are inherited. 50% of the essential tremor are inherited tremors. Then it become a familial tremor. Some causes, what are the common causes? We have to ask some questions to the patients to find out what are the causes of this tremor, whether it's independent tremor or secondary tremor. Medication history is very, very important, because that without that we cannot come to a conclusion, and whatever treatment we are giving, we are only adding another medicine to the existing medication. Asthma medication may make the tremor to manifest. Some of the drugs like amphetamines, some psychiatric and neurological medications. We have to ask about the history of drug abuse, alcohol abuse or withdrawal, alcohol withdrawal. Then the secondary causes are Parkinson's disease, stroke, multiple sclerosis, and traumatic brain injury. Further, we have to look neurologically overall the patient to find out whether patient has any other additional neurological signs in addition to the tremor. Mercury poisoning from food and environment. We have to ask whether what is the job of the person, whether he has any industrial exposure to toxins, what kind of food he eat. All those things are very important to find out the toxic element playing a role in the manifestation of the tremor. And what about the caffeine? Some people take very large dose of caffeine, too much coffee, and that can produce sometimes tremor. And overactive thyroid, we have to look for loss of weight in the history, and then the patient has a tremor. And then we have to look for thyroid function to make sure it is not the manifestation of hyperthyroidism. Liver or kidney failure can produce tremor, and that tremor is called flapping tremor or asterexis. You have to outstretch the hand, give some pressure, then you can see a drop in the hand, very low frequency tremor. That is called flapping tremor. Most of the time, the metabolic tremor is bilateral. It is bilateral. There are times you can get unilateral flapping tremor, but the common metabolic disorder is usually bilateral flapping tremor. Low sugar, hypoglycemia can produce the tremor, and sometimes patient extreme anxiety can have tremor. The tremor has two main categories, so I don't want to go into the very too much detailed classification of tremor. For undergraduate, even for the postgraduate or any even practicing clinician, the basic definition will give us a lot of clue to come to a conclusion and labeling the disease. Resting and action tremor. Resting tremor occurs when the muscle is relaxed and the hands are resting on the lap. Hands, arms, and leg may shake. Commonly, hands are affected. So you have to make the patient hand to sit on the lap. Then you have to look for the tremor. It can come intermittently or it can come immediately while you position the hand in the lap. It is seen commonly in Parkinson's. Usually in Parkinson's disease, you get this kind of resting tremor. Action tremor happens with the voluntary movement of a muscle. When you do a voluntary movement, then the tremor manifests. Many of the tremors are action tremors. Many types and many are overlapping types. So sometimes you can see a combination of tremors and it can have a mixed tremor. So we have to, there are times a certain proportion of essential tremor patients will get resting tremor over a period of time. They may manifest Parkinson's disease. We should not tell the patient you may develop Parkinson's disease if they don't have Parkinson's disease, but a certain group of people, small group of people can get into Parkinson after some time, some period of time, not immediately. The postural tremor happens when holding position against gravity, arms in outstretched position. So you have to ask the patient to stretch the hand outstretched and spread the fingers, and you have to look for the tremor. You have to, then that gives a clue that it is a kind of a postural tremor. It is not there in the resting position. Kinetic tremor happens with any voluntary movement. Intention tremor make an intended movement toward a target. So usually we'll do a finger nose coordination and finger to finger nose. And sometimes the patient has too much of tremor, they can injure the eye while testing the finger to nose. So you can do finger to chin or finger to finger test. That time you can see the intention tremor. It happens when they move toward a target. Task specific tremor happens while only doing some task. For example, when they are writing, they get the shaking. It's basically not a tremor alone, it's a dystonia. It's a task specific dystonia. It is called as writer's cramp. And we see these patients in the practice, and they get some botulinum toxin therapy and they become better. So this kind of task specific tremor, and usually the common example is writer's cramp or task is a kind of a task specific dystonia. Essential tremor, one of the most common movement disorder, tremor in both hands and arm during action and when standing still. It may affect the head, voice, and walking. So when you see a tremor in the hand, you look at their head where they have head tremor, they can have SS tremor or no tremor. It can be front to back or side to side. They can have voice tremor, and you can see the voice, there is a tremulousness and really disabling and embarrassing to them. So this tremor can happen in this group of people. And walking tremor, they can have some tremor while walking also. So the tremor can be mild tremor, which may be non-progressive, or can be progressive tremor with manifestation in many parts of the body. It usually appears during adolescence or in middle age. It can be mild and stable or can gradually progress. So there are times patients come to the clinic with a very mild postural tremor. Then they ask me, what is wrong with me? Is it something serious? I told them that it's called essential tremor and it is very mild. Do you want to label it or do you want to treat it? You say, I am just want to know what is it. I'm not interested in any treatment now. I'll come to you if it is troubling. So there are times people want to know the name of the disease. They are not very interested in treating, especially when it is very mild. It can 50% can be genetic. Dystonic tremor is, you know what is dystonia? It's a twisting movement of the body or along the vertical axis. It can be upper limb dystonia, lower limb dystonia. The entire body can have a contortion movement, dystonic movement. When they have tremor along with the dystonia, it is called dystonic tremor. So when the body is twisted, they can have some shaking along with the twisting. That's called dystonic tremor. Cerebellar tremor, which I told you about, the intention tremor. Psychogenic trauma. There are times you see the patients very odd and mixed manifestation. You don't know what is wrong with them. You have a suspicion they are not the normal classical trauma patients. And they have some kind of behavioral issues, which gives a clue that they can have some stress behavior. It can appear as any form of tremor, may start and stop suddenly, and may affect all body parts. It increases during stress and decreases or disappears when distracted. So when you distract them, when you're talking to them, when they are giving some other task to do, that time the intensity comes down, which gives a clue that it can be a psychogenic tremor. Parkinsonian tremor. One of the first signs of Parkinson's disease is a tremor in the hand. Not all the people with Parkinson's disease will have tremor. So if you don't see a tremor, but if they have bradykinesia, mask-like face, and the slow gait, then you keep in mind it is a Parkinson's disease. It can be idiopathic Parkinson's disease, and they don't need to have tremor in all the patients. Resting tremor or pill rolling tremor. You see this tremor, these fingers, they have movement. It's called pill rolling tremor. In olden days, people make pill by rolling with the finger. That's why it's called pill rolling tremor. And there is a pill, someone rolling a pill between the thumb and the finger. It may affect the chin, lips, face, and legs. So look for, when you see a resting tremor in Parkinson's patient, look their chin, look their face, look their lip, and look at their legs. They can have tremor in other parts of the body, and they have the classical, this kind of tremor, and it happens at rest. It's usually unilateral. Sometimes it can become bilateral, and when it progresses, and even the manifestation Parkinson becomes severe, sometimes it can stick on to unilateral. So it can be unilateral or bilateral. And you have to look for other signs of Parkinson's disease. Orthostatic tremor. Rapid muscle contraction in the leg that occur while standing. When they stand, the patient says, my leg is shaky. And it releases while sitting or walking. Some professions like teaching or people in professions where they have to stand for a long time, then those who have this kind of orthostatic trauma is really troublesome to them. And they come to the clinic and complain to you And it is high frequency tremor. It may not be visible to the naked eye, can be felt by touching the thigh. So the patient say tremor, you make them to stand, then you may not see the tremor. Then we may think the patient making the tremor, but it is very important to touch the leg to see whether the tremor is felt. It is usually palpable and you may not visibly seen, and that gives a clue that it is an organic tremor, it is orthostatic tremor. Sometimes people put a stethoscope over the muscles of the leg and they can feel the tremor noise in the stethoscope. So there are people auscultate, people palpate to come to a conclusion it is orthostatic tremor. It is typically relieved by sitting and walking. Tremor terminology, whenever you see a tremor, keep two things in mind. One is amplitude, one is frequency. End-to-hand distance and travels during a tremor. The larger the distance, greater the tremor amplitude. For example, the hand is shaking up and down, and that distance they travel is the amplitude. And the frequency is each shake of the hand is one tremor cycle. How many cycles in 1 second is the frequency. So suppose you have the low frequency tremor and high frequency decided depending upon the how many shakes of the hand, and there is one tremor cycle in every second. That gives a clue whether it's a high frequency tremor or low frequency tremor. So you have to describe the amplitude and the frequency of the tremor. This is the last tremor, which may not be very important to undergraduates, but it can be nothing wrong in knowing that. And postgraduate is useful, and we may see these patients in our practice. It is first described in 1904 by Gordon Holmes. It is 3 to 4 Hz flexor extensor oscillation, present at rest, exacerbated with posture, and intensified with action. Older description in 1889 by Benedict described the tremor secondary to mesencephalic infarction. Benedict described before the Holmes, but I think the definition pattern, all those things, the description become more refined in 1904. This tremor is also known as rubral tremor, mesencephalic tremor, or thalamic tremor. Typical cases have been described with lesions located in other areas. So I remember when I was a student, we used to be told us this triangle of Gillen-Mallaret and central tegmental tract, and also then that is called as red nucleus tremor. But all those concepts is changing, and there are cases which are described typically as rubral tremor or mesencephalic tremor, and they found lesions in other areas of the brain. Red nucleus experimental lesions fail to induce persistent tremor. In a laboratory setup, the red nucleus experimental lesions, they fail to induce a persistent tremor. So it not necessarily the lesion should be in the red nucleus to manifest as a pattern what we described before as a red nucleus tremor. Current definition is rest and intention. It is basically the Holmes tremor is rest and intention tremor with sometimes irregular amplitude. Postural tremor is also present in many patients. So you see a resting component, you see an intention component, you see a postural component, all component you see, and that gives a clue that we are handling a different kind of tremor. Slow frequency tremor, it is less than 4.5 Hz, which I mentioned before. It is in symptomatic tremor, the imaging studies are abnormal. So you see, you do the MRI brain, and you see there are lesions in the brain. It gives a clue that the structural problem which I mentioned, like thalamus, all those things, gives a clue that we are handling a Holmes tremor. As I told, there are times the lesions are outside and you still get the Holmes tremor. In some cases, no lesion can be demonstrated. That is the importance of image negative patients where you get this. So the description of the tremor is very important. Whenever you see the patient, you describe whether it's a resting tremor or action tremor, what is the amplitude and frequency of the tremor, whether it is postural or whether it's active. All those description gives a clue. Then you go to the diagnostic possibilities. Then your localization is very perfect. Tremor develops between 1 to 24 months after CNS insultation. I have seen patients coming after 6 months and manifest this tremor when the insult happened 6 months back. It is not uncommon, and you see after 1 to 24 months after the CNS insult that this kind of tremor can start. But the etiology is what happened some time back. This delayed onset may be due to neuronal plastic changes. It is assumed that a double lesion is required to develop Holmes tremor, that is dopaminergic nigrostriatal system and the cerebellothalamic cortical or dentato-rubro-olivary pathway. So you can have a combination of these 2 among or 3 among these combinations to get this kind of Holmes tremor. So it's not necessarily a particular lesion produce that kind of particular tremor. So in conclusion, that so whenever you see a tremor, always ask about how long it is present, whether any family history is there, and find out whether it's a resting tremor or action tremor, and you see the frequency of the tremor, amplitude of the tremor, and look in the other parts of the body where the tremor is there only in the hands, and other parts of the body is also there. Ask for the drug history, look for other underlying medical disorders, then describe what you see, then name the closest to tremor possibility to come to a clinical conclusion. Thank you very much for listening to me.
Very excellent talk, sir. Very